Daphne Sakharopoulos, who is also an ICHOM board member, and Daphne is also bringing a fantastic panel with her. So the next session is about why patient organizations' roles are crucial to driving better patient outcomes. Please welcome to the stage Daphne Sakharopoulos.
Thank you.
Hey, come on up.
So look at custom
All right, good morning, and thank you, Suzanne. So as Suzanne mentioned, I'm Daphne Sakharopoulos, and I'm just honored to be here today as a member of ICHOM's board. So today, where did Alan go? We need to get Alan up here. Today, we are going to talk about, sorry?
Where do you want me?
All right, we're going to talk about patient organizations today and the crucial role that they play in driving outcomes measurement. Before we get started, I wanted to reflect on last night's dinner, where Professor Elizabeth Teisberg told us her story of how she came to work in value-based care. And I didn't know this until I heard her last night. She told us about an experience she had with the healthcare system when she was expecting her baby, ultimately her son, and how she felt failed by the experience, failed by the lack of data, failed by frankly, the entire system. And that led her to her research, her work, which ultimately resulted in the seminal publication that she co-authored with Michael Porter on redefining healthcare. And I just thought it really struck me how this all started, right? It all started with a patient. So with that, I want to switch gears from that incredible session on technology and shift more directly to the patient perspective. Ultimately, the reason we are all here. I'm thrilled to have 5 representatives from 5 extremely varied patient organizations, 2 of them here in person and 3 here remotely, who we can see on the big screen there. So we have Kelly Page with Movember. We have Alan Bulk with the National Patient Advocate Foundation. Kira Drohan joining us virtually from the European Federation of Crohn's and Ulcerative Colitis Association. Theo Koster with Andrea, and also a board member of the Linnaean Group, who we've been privileged to hear from as well over the last few days. And Judith Takas with the Canadian Cancer Society. So welcome, everyone. And what I'm going to ask our panelists to do is, as we get into the discussion, to give a brief introduction to both themselves and to their organizations. I think we're all familiar with Movember at this point, the people who gave us those mustaches in our goodie bags and last night. But I think it's important for all of the panelists to introduce not just themselves, but their organization. All right, so I'm going to kick off and jump into the discussion here. And the first question I'm going to put to Judith with the Canadian Cancer Society. So the work that you've done to put patients' contributions, their needs, their experiences at the heart of what you do, can you speak a little bit into how, so our audience here can really learn from this experience, how have you brought that patient perspective into research, and any lessons you feel you've learned so far through that process?
Thank you so much, Daphne. I'm excited to share with everyone today and learn from the other speakers as well. So just to start off, my name is Judith. I'm here from the Canadian Cancer Society. I'm a senior manager on the research team. We fund research. We provide targeted support and care, information, and advocacy. So I'll talk a little bit about CCS and then really focus in on the research piece. CCS has a 70-plus year legacy of fueling discoveries and funding what we hope are the brightest minds in cancer research. We are the country's largest national charitable funder of research into 100 types of cancer. We advocate for change in the most pressing areas of cancer policy, including prevention, access, affordability, and support. We provide high-quality cancer information for all people in Canada and promote cancer prevention. And we provide targeted support to help people with cancer, their families, and caregivers cope. We try to take a comprehensive approach against cancer. And we know that patient engagement in research, advocacy, and care can make a meaningful, systematic difference. And so I'm going to speak about how patient involvement in cancer research and research funding is creating positive change in a culture shift. And for some context, we fund approximately $30 to $40 million of cancer research a year. At the Canadian Cancer Society, we strive to fund scientifically excellent research that maximizes the relevance and impact to people affected by cancer. And in order to engage patients meaningfully and systematically, we co-created with patients and researchers a patient engagement and research plan where all team members were equal. This plan lays out our guiding principles and other aspects of how we would work with patients, such as compensation. It also included critical, high priority, and important patient engagement activities for meaningful engagement across all of our research funding stages. Our team of patients, researchers, and staff completed the plan this summer, and already about 9 of the 13 patient engagement activities within the plan are underway. For instance, we engage patients, survivors, and caregivers as reviewers on our research review panels. And we engage patients as members on our advisory council on research and as program advisors to help us co-develop new research competitions. We require research applicants to our research competitions to involve patients and other stakeholders meaningfully in their research, in the co-creation of proposals, and as key members of the research team. And creating the plan and implementing these activities has taught us some lessons, some very important lessons. So I'll share a couple today. The first one, patients and researchers working together can improve our research funding processes and enhance the design of new research funding competitions. For example, patients played a critical role in the co-development of our 3 current research competitions, and those are research competitions on knowledge synthesis and implementation, competition on health equity, and one on low survival cancers. Patients and caregivers also work as reviewers alongside scientists and clinicians to assess the relevance and potential impact of research proposals in all 3 of these competitions. And for all 3 of these research competitions, it's required that research teams include patient partners as meaningful, equal team members in their projects and applications. Another lesson is that patients make important contributions to our work on things like compensation, safety, power dynamics, and equity. Our patients are strong advocates of incorporating equity in our research. For instance, they have asked us to analyze our data by intersectional identities to highlight input from underserved communities. And they've also worked with us to create an equitable compensation policy that we now use for all patient partnership in research. And maybe I'll share one last lesson and then pass the mic. On a micro level, patient involvement has built skill and confidence in research and engagement in our patients, in researchers, and staff. We continue to foster researcher-patient relationships and skills through research review, training in our funded research. And this is really an ongoing lesson we're still learning. Pass it back to you, Daphne.
Right, thank you. Just terrific. The spirit of co-creation, a word that you used, really came through. Like, I don't think anyone could think tokenism in the way you've described that. That's some heavy-duty involvement. So if we have time and we circle back around, I want to come back a little bit to the how, because I think for many, getting that first step of including patients, not that hard, but getting into it and actually the weeds of that's quite a large body of work that you managed and described. But I'm going to keep going with our panel, and I'm going to put the same question to Kira Drohan with the UC Association. So we'd love to hear from you. If you could again just introduce yourself, your organization, and address that same question.
No problem. Hi, everybody. My name's Kira. I'm the Vice President of the EFCA. So we're a collective national organisation or a third umbrella organisation for patients with IBD, which is Crohn's and ulcerative colitis. So in total in Europe, we have 10 million patients who suffer from IBD. So we represent 46 member associations of each individual country across those 9 continents. So I suppose you could question whether we're European or more global now at this stage. So we've done a lot of work in relation to, I suppose, dealing with and helping with patient. Now we refer to it as patient-related outcomes, more so than shared decision making. And for us, we've been involved with a huge number of patient advisory boards. We work with the European Health Forum, we work with Secure IBD, DG Sante, and the Global CPF Patient Organisation. So it has, and we've sat on a number of advisory boards as well. And I suppose, Daphne, just in relation to you, that it's not easy for us, and we've had our challenges along the way on trying to get there, but we now sit on a number of advisory boards, which for us has been a huge battle. But we are there on, I suppose, mirroring what patients want and what clinicians want, and trying to marry them up. And that's why we refer to them as patient-reported outcomes, to allow for that it is the patient has reported it. So currently we sit on the IBD Patient Council. We've been taking part in the Global Patient Summit, Patient Engagement Council, and the International Patient Council as well. So for us, having our voice heard is hugely important. I suppose Rome wasn't built in a day. So that's why we say that it's taken us a while to get there, but we have got there. And I suppose, with what you said, Judith, was that patients involved, their perspectives are being heard, which for us is really, really important. And we have had to trying to marry up that relationship between the clinical side and the medical and the research side. The only way to do that for us is having patients' voices heard and patients sitting at a table. Now, we have noticed it can be extremely difficult because what we as patients think and what clinicians think can be very different. So we've looked at the cost of healthcare, the psychological effects, why we always campaign for a multidisciplinary team for our patients, so that it's the whole patient. It's not just the part of the body that is affected. It is the whole patient that is important. So I suppose we've had major eye-openers on where our language is very different, and neither are we clinicians, but we've had to look at it. But it's similar, a patient with terminal illness might be more concerned with their level of comfort and their pain and their ability to live longer. We're trying to live day to day, and our patients are trying to live day to day. So we're looking at the patient satisfaction with clinicians. The quality of life has been a huge focus for us, because different stages of life, it can change, and the focus for the patient changes. So I'm honoured on behalf of EFCA to take part. I'm sorry I can't be in Boston, and I'm dialing in from Ireland. But over to you again, Daphne, then as well.
All right, terrific, thank you. I definitely heard you say it's not easy. It's difficult, coordinating across so many different countries and different groups. So thank you for your perseverance. I think what you're showing us is it can be done. It's not trivial, it's not easy, but it can be done. So thank you. All right, I'm going to turn now to Kelly, who's here with us in person, and put the same question to you about the why.
Thank you, Daphne, and to ICHOM for allowing us to be part of this conversation. And that there's been so much awareness about Movember these past few days, appreciating that. I think what I wanted to share was maybe a little bit of the origin story of how we came to join forces. And for Movember, our three cause areas really being prostate, testicular cancer, and mental health. In prostate cancer, as Movember grew around the world, we're active fundraising efforts in 19 countries. We have active prostate cancer programs currently in 27 around the world. It became very clear just over 10 years ago how fragmented the collaboration was, and how inconsistent language and data there was around prostate cancer, even though there were really excellent programs being developed. And so when ICHOM and Movember were match made, I'd like to think it was in Germany at the Martini Clinic, it was really with this shared mission of how much stronger we could be if we collaborated together. And so since then, Movember has funded national registries, international registry collaborations with localized and advanced prostate cancer in mind, and with the application of the standard sets. Also requiring and requesting that survivorship initiatives or personalized care initiatives also take on the clinical data set or minimal set, but most importantly across every single one of the programs I've just mentioned is the inclusion of patient-reported outcomes. And so I think about the core PROMs in the localized prostate cancer set, and that while we're not the only ones supporting the translation and validation of those measures in multiple languages, I think sitting here today, I could say in the last 10 years that's probably been translated into at least 15 other languages than its original English. And how powerful that simple act is. So the why for us as a men's health charity, really being the voice or elevating the voice of the community we serve, is that at multiple levels, whether that's individual behavior change, working with clinicians to improve care, working with health systems to improve care, or now really moving into this conversation around influencing systems change. And the real value-based healthcare conversations around cost and what defines quality. For us, it's championing how important it is that that quality of life and quality of care is really defined by what matters most to patients. And we have to be capturing it to truly know. And at every level, from research to the development of websites and digital health products, to our registries, and that why really needs to be inclusive of patients and their partners and caregivers, and really making sure that at every level, and I like the use of that co-creation and co-design, that that's at the heart of every single thing we do. So.
Terrific, terrific. I like the emphasis on the international nature, the understanding of disease, right? There are certainly cultural aspects that might have to be considered, but our ultimate goal here is to learn from each other, not just the EHR of the patient who was seen just before me by the same doctor as Jamie in the previous panel talked about, but we can actually learn across countries too, and listening to the patients that way as well. So thank you. All right, I'm going to turn to Theo, who is joining us remotely as well, and ask him again to just briefly introduce himself, his organization, and to, again, this central first question of the how.
Yeah, thanks. Yeah, my name is Theo Koster. I'm here based in the Netherlands. I've personally been involved with patient advocacy for over 10 years now. First as a patient myself, and after regaining my health as an individual with hands-on experience. I'm currently the CEO of Andrea, the digital research environment, but I'm here today as a member of the advisory board of the Linnaean Initiative in the Netherlands. And to give you some background on Linnaean, the origin of the Linnaean Initiative was closely intertwined with ICHOM. It was 5 years ago, in 2017, we started at the actual ICHOM conference of 2017. There was a side event at the Dutch embassy, and there was all this positive energy surrounding the concepts of value-based healthcare. And the Dutch embassy in Washington is located at Linnaean Avenue, so this is where the name comes from. And at the event, at this embassy conference, there was a firm decision made that we should channel all this positive energy surrounding the concept of value-based healthcare in what was then christened the Linnaean Initiative. This was 5 years ago, and today it is an open network, Linnaean, a network organization of over 1,300 professionals, and we use what was called a bottom-up approach, which means that everyone can join if they want to add value, and they come from across the healthcare sector. So they could be care people, cure people, people with an insurance background, people from government, pharmaceutical specialists. And of these 1,300 professionals, over 44% has completed the full expertise profile. And what Linnaean does is we try to be like a sandbox to discover best practices to implement value-based healthcare. And what we discuss both failures and successes, because you learn from both of them. And today, we have over 150 real-world stories published, interviews published on our website, linnaean.nl, free to access for everyone. There are 14 knowledge products which have been developed by focus groups. And these knowledge products are like how-to manuals and discussion diagrams and whatever has grown from real-world experience. There are over 10 focus groups that on average, once a week, a focus group actually meets and tries to generate new insights. And every year we have 5 major events in the Netherlands. So it's quite a success today. And well, the network of professionals is open, as I said, so it is accessible for anyone who asks us a question or wants to access the information on the knowledge at the website linnaean.nl. And the first key to success I would like to share with all of you from Linnaean, we discussed this heavily, but I think our strategic value is that we have no financial position nor a political position or ambition in the process. So we are a complete neutral player. We are strictly independent, We are what we call by nature elusive. We don't try to establish a position. And our ultimate goal is to, after having discovered how to fully implement value-based healthcare and patient-reported outcomes, to actually liquidate ourselves and not being a player in any political field or financial field or any other power is actually a very good position to be in. So I would like to invite all of you to visit the website and figure out and reuse what we've already discovered.
Terrific. So you're trying to put yourself out of business by achieving your goals. That's a terrific aspiration. Exactly. Absolutely. I also liked what you said about discovering best practices. I think sometimes people come in and assume the goal is to teach, to instruct, to disseminate the best practice. But I think what you're pointing out is that through the involvement of the patients, we're actually learning, we're discovering, we'll evolve, not just the standard sets, but the pursuit of quality, the pursuit of that continuous improvement. So thank you. All right, and last but not least, we have Alan here on stage with us. So I'm going to put that same first question to you and also ask you to remind you to introduce yourself and your organization.
Sure. So I'm Alan Balch. I'm the CEO of the Patient Advocate Foundation as well as the National Patient Advocate Foundation. Great to see all of you this morning. We're part of the safety net in the U.S. healthcare system. So we provide financial and patient navigation assistance to hundreds of thousands of patients across the U.S. who are primarily low-income patients who are facing social and financial risk. We don't deal with anything clinical. We deal with all the other stuff that we know get in the way of patients and the outcomes that they deserve and they're seeking in their healthcare journey. And then we have a health system change arm, which is the National Patient Advocate Foundation. We actually wrap a health services research infrastructure around the services we provide so that we can learn from those patients that we're helping, what is it like to be a patient facing health inequities and health disparities in the world's most, I would argue, complicated and expensive healthcare system. How can we make that system work better for you?
Terrific.
You want me to address the health
I think you mentioned that you have an emphasis on low income, patients with low income, and unfortunately it's often correlated with diversity. Could you speak a little to that? Yeah, sure. So, I think two high-level things, and then I'll drill a little deeper in just a few minutes. I think it is really important that we think about outcomes that matter to patients, right? But I think as we're building that infrastructure of insight, making sure that at the table of that co-creation and learning what's important, that we make sure that those voices represent low-income and racially and ethnically diverse patients. Because one thing I can tell you, I know for sure from what the work we've done, is there's a difference between what matters and what's important to patients. Some of that variation depends on socioeconomic status and other lived experience of patients. So if you don't build that into the process of insight, you're going to create an outcomes measurement system that is inherently biased towards those that are more engaged, more white, more engaged, and more educated as patients, and you're going to lose that opportunity to really think about how to develop outcomes that matter to all of society, especially those that are underserved and really are challenged by other, what we might call social determinants in the broader world, not just within the healthcare system. So that's just a starting point. I think if you're trying to figure out where to start, and I loved what Peter said about, there's this titration on standardization in the healthcare system, which is great, especially when it comes to clinical dimensions of care. I mean, there are opportunities, right, to personalize the clinical care, right, with diagnostic tools and precision medicine. But beyond that, there's a real opportunity to personalize care to the patient outside of the clinical aspects of care. And I think this is really the heart of personalization. And at the very least, especially with low-income, socially vulnerable patients, a lot of the problem and a lot of what's driving health inequities and disparities is at a fundamental level is a lack of trust and a lack of engagement. And the way you start to build that trust, and we've asked patients this over and over again, that they have to feel respected, they have to feel listened to, and they have to feel that their care is personalized to them. And again, that personalization of care doesn't necessarily have to do with the clinical aspects of care, but the lived experience of care and how well does the care team really want to get to know them and really address their personal needs. And that's where there's tremendous variation what a patient needs. So I think what that translates to, and there's a lot of efforts, and we're part of some of these measurements efforts, you can measure the extent to which a patient feels heard and understood.
in the healthcare process, especially when it relates to things like shared decision-making around care planning and care selection. We have to get away from this idea that shared decision-making is just between a clinician and patient at the point of care about clinical dimensions of care, and that it doesn't also extend to other points where key decisions are made for patients, care planning and then measurement selection. So this idea of co-creating the care experience with a patient and personalizing it starts with care selection, goes to care planning, and then speaks to how do you measure the outcomes of care. And I think it's really important to kind of separate in the way you start to create that differentiation between standardization and personalization, separating out the clinical dimensions of care and that clinical journey, and then really starting to think about that patient journey and that patient experience. Those are two different journeys. They interrelate and overlap in really significant ways. But we often sort of just focus on what's the clinical aspect of care and how do we measure those clinical outcomes, and that's really important. And then how do we standardize care? Because some outcomes, some of the disparities in care and health inequities are driven by patients not getting the best standard of care. So sort of titrating on standardization of care and the outcomes measurement associated with it is a good thing. But then if you think about the patient experience, there's so much opportunity to personalize care and create care pathways around the patient experience. And how are we addressing the patient's needs and making sure that we're personalizing the care to them? Because what we know is when these patients leave the four walls of the clinics, the things that get in the way of them achieving their outcomes, their clinical outcomes, are really basic things. Housing, food, transportation, the inability to take the appropriate time off work, caregiver burden, the overall cost of care, even in systems where the cost is paid for or borne by the government or their employer. There's a lot of other costs that come directly out of a patient's pocket that really get in the way of their ability to adhere and be able to follow their care plan. So we have to think not just about the cost of care as it relates to the health system and the benefit design, but think about the cost to the patient. And we deal with patients that have really significant chronic disease, over 800 different diseases in the population we serve. So I'll just leave you with this, and I know I've probably gone over my 5 minutes, but solving health inequities and personalizing care is in 5 minutes. Let's see how I do. But I do think there are opportunities to move beyond this idea of what's important to patients as sort of a glittering generality and getting down to really specifically what are the dimensions of the patient care experience that are both actionable and can be personalized and actually have bearing on a patient's ability to get the outcomes they deserve from the clinical therapy that's being prescribed to them or they're trying to adhere to. And so I think that's where, as a coalition of the willing, so to speak, we can try, and that's what we're trying to do. We have a lot of academic partners in our work where we're really trying to define what are those 5 or 6 things that are really critical to patients, and then making sure that you surface those issues about the patient experience early and often in the patient care journey. And then you measure the outcomes associated, not with how well you dealt with those issues from a clinical, or don't tie them into the clinical dimensions of care, but if you're trying to help a patient with food or transportation or housing, then the outcomes you're measuring is how well did you help that patient, or was the patient supported in those dimensions of care. And I can unpack this even more, but this is where decision support tools and technology can play a real role in helping to both identify what's important to patients, again, not just generally, but really specifically around what is it about your care experience where you're going to need to feel supported and cared for that we know has bearing on your ability to achieve the clinical outcomes. But let's not wrap that measurement up into some sort of clinical or expect that work to have some bearing, necessarily a one-to-one correlation or causation with the clinical outcomes of care. Let's measure that outcome as how well did we make sure a patient felt listened to and understood. And in that process, do we identify the 2 or 3 things that we know are going to be critical to addressing to make sure that patient gets the clinical outcomes that they need and deserve. And then let's measure how well we did with getting delivering interventions against those outcomes related to, again, for us, it's issues like food, housing, transportation, time off work.
No, thank you. You've reminded me of a long-standing debate with my husband who works in education, and I've spent 20 plus years on the business side of healthcare, at healthcare companies, at startups, patient organizations, but like, could we actually do more to impact healthcare if we fixed education, right? Because as you've reminded us, it's actually life.
Yep.
It's not actually just the symptoms of your condition that we're trying to address here. It's actually living life to your fullest potential, doing the best you can given your condition. So coming back to this, what you again, I think very eloquently outlined around equity. The underrepresentation of certain groups in clinical research has been extremely well documented. I think everyone has the intention, right, to do better, and I'm sure everyone in this room aspires to. I'd like to put it back to our remote panelists, and Judith, I'm going to pick on you in Canada, where I used to live, and for those who don't know, there is extremely large immigrant populations in Canada. I'm an immigrant myself who lived in Canada for 4 years. But I'd love to hear your take on how do you address this in the work that you're doing?
That's a great question, and happy to be picked on. I'll share, I'm also an immigrant in Canada, so this is not uncommon, as you say. But you're right that we have work to do. Many of our, especially our clinical trials, are or have been up until this point largely not as diverse as reflective of the population. And some of the things that we're hoping to do within Canadian Cancer Society are looking to, at this point, make connections and learn from other groups. So we're reaching out to communities to better meet them at their table. So not have them come to our table, a little bit of what Alan was getting at, but what do they need to be able to participate? How do we make systemic changes in our work? How do we, in our case, change how we fund our research so that our researchers can offer opportunities and work as equal team members with people from diverse communities. And we also partner within other organizations. We're working particularly, I'm excited for this one, it's a framework for bringing clinical trial opportunities to rural communities. So this one is, I don't know how unique it is to Canada, but because Canada is so large and there are a large number of rural populations and Indigenous populations in rural areas, we're looking to see how we can bring the opportunity of clinical trials to some of these areas. So we're co-developing a framework with a number of other organizations to make that happen.
All right, terrific. And Kira, I'll put the same question to you if there's a nugget you want to add on equity.
I'm so glad I didn't have to go after Alan. So I think for us, one of our biggest things about equity is because we represent so many different countries is what we expect, what I might expect in Ireland as a standard of care or quality of life or access to medication isn't what is across every country. And that for us has been a big challenge to look at whether it be government funded or that they can all affect the quality of life for us and a patient outcome report, because it depends on where I'm actually living. So it doesn't even come down to my colour, my anything. There's nothing. It's about where I live, where I have chosen to live and what access I have, and whether my quality of life is higher than others. And that for us is a lot of work we still have to do on trying to standardise things. So we work a lot with the European Parliament and MEPs to try and have, again, the patient's voice at tables where they're making government decisions and European decisions. But it's a real challenge. And Judith, just in relation to your framework, we're looking at this year and next year, our focus is IBD with an age, and one target market we really want to look at is the elder. And I suppose our aging population for our patients with IBD. And we're already trying to think of how can we get that information to them and from them. Because you may not be able to send a link, you may not be able to send a message. So there's a huge amount of factors that come into play.
Thank you. And Theo, is anything you'd like to add to this topic?
Yeah, well, Linian is of course very much focused on implementing value-based healthcare, so that's our perspective. And we've been working in these 5 years long and hard to actually get patients involved in how to implement these procedures. And the difficult thing is that on the one hand, in the Netherlands, value-based healthcare outcome measurement, patient advocacy is by now a formal policy by the Ministry of Healthcare. Yesterday, Minister Ernst Kuipers actually spoke about that. And there is a sector-wide agreement. And in the first line, in the first sentence of this sector-wide agreement, there's patient involvement mentioned. So it is on the procedural and political agenda. Of course, Linian comes from implementing bottom-up. And well, from private experience and through Berlin, I can confirm that if a patient is able to discuss his own patient-reported outcomes, it is very valuable, both for a patient and for caregivers. But then there is the real hard second question of getting it into the hands of all these patients. How can you actually involve all these patients? And our experience, which is probably shared by everyone, is that in practice, in reality, you will only get patients who have these high interpersonal skills, who are knowledgeable, who are digital, who are able to discuss their case in the abstract. And it is very difficult to, next to impossible, to involve people who struggle with, for instance, language barriers or have limited digital skills or whatever other limitations they have. And well, I've drawn the conclusion, which is more or less my personal conclusion, and Ellen actually mentioned this before, as a coalition of the willing. And I think to get to implementation of value-based healthcare, implementation into procedures, I've come to the conclusion that we can learn from history. And since we are addressing a conference in the US, let me draw a parallel from history, US history. How was the route to the west of America opened? Well, there were stages. First, there were these trailblazers who opened up the Oregon Trail. And you needed a few hardy individuals, like in US history, Lewis and Clark, who were able to venture west and into the unknown and open this route to California. And once the route is created, the first settlers can follow that trail, slowly advancing with their ox-hauled wagons. And then after that stage, you get into the, once the route is well known, and then the masters can follow, and they actually did by using the railways and today by plane. So we've actually decided that we are currently in a situation where we have to rely on the coalition of the willing and able and take these trailblazer patients to help evolve patient-reported outcomes and help evolve the implementation of value-based healthcare in the different healthcare systems across the world. And from there on, open up the route for other patients to actually follow that.
I love the analogy to US history and the literal trailblazers. And I think of this group and the 10 years of work at ICHOM and the many pioneers before who were really laying the groundwork for what, frankly, realizing the promise of value-based care and realizing the impact that we can have on patients. All right, I'm gonna switch gears to Kelly, who's with us. As you referenced in your opening comments that you had actually implemented the ICHOM standard sets, I'm wondering if you can share just some perspectives as a patient organization on that process. And if you also want to touch on the equity question, given November's presence, that would be terrific as well.
Thank you. And I might start there just very quickly because my esteemed panelists and peers up here have made so many fantastic comments. I think for the conversation around health equity and outcomes, we have to really focus on, and what we are trying to focus on is inclusion upstream. Because if we don't get representative inclusion upstream in what information we're collecting and who we're involving, then we're going to limit ourselves in the initiatives, the intervention, the understanding downstream in terms of really trying to make a difference. And we see this in research, we see this in care delivery, and that's not just in the US where we have maybe some more complex challenges from an access point of view. And so I think that how to do that, of course, is not easy, and the answers are very localized and different and need to really be, I think, bottom up and top down in terms of how to address that. In terms of the actual implementation of the sets, I think some of the most powerful collaboration in the establishment phase is really the multidisciplinary inclusion of who's at the table, making sure that patient advocates or advocacy organizations are also there, challenging and thinking about the applicability of that work. Of course, it's the champions, it's the people in this room that are usually driving those conversations to get started or to push for the sets to be included or to an extent to start. And I think that that is all very important, but we also have to think about who's not in those conversations. Whose hearts are you trying to win over? How do we convince Mickey that there actually is an ICHOM overlap and we can't? If he's still in the room. There's probably certain conditions that are more mature and further down the track, and so there are places to start without taking everything on. And I think the other one that is really coming to mind is taking a pause to ask and look around. Are there groups or initiatives similar to yours somewhere in the world, or even in another disease condition or tumor stream in the case of cancer, to really leverage and to learn from? Because there's so much work that has been done. And where starting somewhere is so much better than delaying starting at all. And it isn't always easy, and things do take more time than we ever anticipate. But I think that where that collaboration is strongest, identifying where there are shared measures, shared overlap globally is so, so important, even though some of the solutioning and how these outputs are ultimately used and best applied needs to come back to that local application.
So a theme of perseverance is coming through again, right? Just taking the first step. It is hard, as our panelists have said, but it can be done. In a minute, actually probably 5, I'm going to take audience questions for our panel here. So I invite folks to think about that and maybe start getting the microphones to people with questions. But while we do that, I'm going to put one more question to our panelists and ask for a bit of a rapid fire, lightning round responses. We always, I think, as humans, right, we learn more from when we mess up, when we fail, when we try, and then we try again. I would love to hear from the folks who have this deep experience in bringing that patient voice to this process of outcomes measurement. What are some of the lessons learned on the failure side so that, again, our delegates here don't make the same mistake or benefit from your lessons learned? All right, Judith, I'm going to pick on you in Canada again. First on my screen here.
Sounds good. Happy to share because I think you're right. Perhaps I think the hurdle I want to talk about first is around change and culture change. And just the change in culture change takes time. When I look at CCS, we've had community members and lay reviewers who review research proposals, so people who are non-scientists, for almost 20 years, and a formalized reviewer program since 2010, and yet we still have researchers who may be surprised or hesitant to work alongside patients. There's hesitancy, and we found that supporting researchers and managing this hesitancy and culture change really was and is a big hurdle. And so a little bit about our approach. There's no single solution we found that actually does work, but what we have tried is a layered approach, and that seems to be what's moving the needle. So in terms of communication, we introduced the idea of patients and caregivers and the importance of it as equal members in our research funding, and we continue to communicate about this with our advisory councils, our researchers, review panels, on emails, social media, so wide communication. For instance, we're launching a communication plan on the importance of patient engagement in research in January, and we've created several websites about our approach to patient engagement and to support our researchers in how to engage patients and stakeholders. Another piece, we now recommend or require patient and stakeholder engagement in all of our research competitions. So we actually note to reviewers to consider determinism. That was something you mentioned earlier, Daphne, and other risks in meaningful engagement when they're scoring applications. And we offer training and engagement, and we're looking to do more of this in a targeted way. So for instance, our staff, that's where we started, has undergone trauma-informed engagement training to better understand the potentially traumatic experience of cancer and how to support people affected by cancer who generously share that experience with us. Maybe I'll say one final piece. I think I'm going over my rapid fire time. The important consideration we have is really to bridge the gap. So when we looked at the landscape, researchers have and operate within a specific culture, and that is different than the culture that patients and caregivers might experience. And so to bridge that gap so that patients and researchers can come together to understand each other and to share and to learn, that's been really the main driver to change our research culture. So for instance, we bring researchers and patients together in meet and greets before panel review meetings. We have researchers and patients both on our advisory council working to advise us on research directions and priorities. And we're piloting a patient researcher matching program to create more of these bridges. So it's really the key of not offering training, learning, or opportunity to any one group, but trying to foster the shared experience.
Perfect. So I'm going to take one more. Does anyone have a failure they'd like to highlight? Alan, I see you there. Oh, no, go ahead.
Theo.
Go ahead, Theo. Sorry,
okay, thank you. Well, we started as Linnaean in the Linnaean Initiative in 2017, and we recently had our 5-year anniversary conference. And what we, looking back, learned, and this might be specific for the situation in the Netherlands, is that on the implementation of value-based healthcare, we were focused and we got response from cure and care, medical cure, medical care. But mental health care sector in the Netherlands actually just starts now. So the biggest lesson in failure that we learned is that mental health care might be even slower to pick up value-based health care.
Terrific, terrific. And I'm going to just, in the interest of time, we have about 5 minutes left. I'm going to open up to audience questions. Is there one out there? It's hard for me to see, so I'm hoping folks with microphones are roaming. Terrific.
In many of the discussions we've had yesterday and today, the role of governments to drive, change policies and drive system change is key. And there was a discussion yesterday where somebody said, well, so we need constituencies that will influence the policymakers actually to do these quite radical changes that are needed, whether it's requirement for outcomes measurement, transparency, etc. And I could think of no larger and more influential constituency than patients, because we're all patients or will be soon. And so if patient advocacy groups would take a much stronger stance and maybe together discuss and argue for politicians that we need these changes, I think you could have enormous influence. Is there such a forum for, you all represent different patient advocacy groups and different diseases, where you together could drive this discussion with our policymakers?
There's not a global one, no. I don't think. So I think there's certainly an opportunity. I mean, I probably would argue, I don't know the global patient advocacy world entirely, but I've definitely interacted in different countries with different advocacy groups, and there's not, I think part of the challenge is, there's not, in the US, the patient advocacy community is pretty well healed, pretty engaged. I think in other countries, there's differences in how that manifests itself, and then some countries just don't have patient advocacy groups, at least nothing approaching what other more sophisticated countries, so to speak, have, at least from the patient advocacy perspective. So I think there's a challenge inherently in just the disparities of the capabilities and the size of patient advocacy organizations to even start that. So I think it's, unfortunately, probably be more country specific. And I do think, at least, and I can only speak to the US, I think there's sort of a macro and a micro level opportunity. I mean, I think we tend to define policy very much around like what governments can do. But as a political economist, I think I would say that policy is defined all the time by lots of different institutions. It's really any rule or any set of policies and behaviors that dictate how something is distributed or how people behave in an institution. So there's policies that are set by hospitals, by insurance companies, by employers, by all sorts of actors. And those all represent opportunities to influence how health system is delivered and the patient experience in that context. So I do think there's certainly an opportunity to influence government. I would also argue for maybe something a little bit more diffused. We're not just trying to influence government, actually trying to influence other institutions that have a really, like ICHOM, like ISPOR, and other agencies that have the ability to influence the health system, maybe not through government channels, but in other ways. Decision support tools, outcomes measurement. All these things have a really incredible bearing on the patient experience, but they might not all be sort of mandated or influenced through government. policy, but there are other actors that can work with patients and patient groups to figure out how can we bring change to the healthcare system, both through more traditional government channels, but also through maybe less traditional channels where you can get multiple stakeholders together and say, we're gonna make the health system better. We're not gonna wait for a government to do that. We're gonna see what we can do ourselves by working with patients and really thinking about that patient experience. And again, the starting point, and this isn't something government can mandate, making sure patients feel listened to, respected, and that their care is personalized to them is the starting point anywhere you are in the world.
So despite his profession as an economist, I hear a vein of optimism in what you said, which is and a challenge.
It is the dismal science.
It's the dismal science, right? So, but I think it's a challenge to all the delegates to not think in terms of the constraints. Oh, the government policy hasn't yet been set to do X, Y, Z, right? But it's more about the aspirational, you know, what can we do? And Kelly, to the point you made earlier about taking that first step.
Absolutely, and I think, you know, Movember as an organization, we like to make noise and to be disruptive, and I think to respond to the question, probably just now with the maturity that we have organizationally, thinking about how to do that in a better way and on an international scale as well as a more localized one. And prostate cancer for us might be where we have the most established mechanisms and conversations and maturity and even information. But I think what's really critical is acknowledging that when we're talking about things like driving for adoption and usual care of patient-reported outcomes, we can do that at the pointy end for those with prostate cancer, but of course knowing that who will benefit is a patient audience far beyond. And so organizationally, and even being a men's health focused organization, I think thinking about some of these broader conversations that absolutely we should get behind and how to connect better, how to partner and create the forum, I think we need more to address exactly what was just raised.
Right, and Stefan, I think we have to take on some of that challenge as well. We do have the opportunity, we have a break coming up, so I know there were some more questions, but I'm gonna ask that we defer them to the break. And I would just ask you to please join me in thanking this incredible panel. And I will turn it back to Suzanne, and let's redefine healthcare together. All right, thank you.
Thank you so much.
All right.